clarification on the open label study. How large is it going to need to be, and is it only going to be the rollovers, or are you going to be adding any new patients into that? And have you essentially for the safety guidelines, are there a certain number of patients that you need to treat that you still need to satisfy? And then separately on reimbursement patterns, I'm a little bit curious. Right now, are patients limited to only 3 or 4 times per year for reimbursement of the current toxins? And when you think about reimbursement, are they also going to be limited to 2 times a year, or is there a specific measurement where you have to, go back to baseline, you have to go back to the 80% before you're able to get treated? Just wanted to understand the reimbursement patterns a little bit more for toxins. Thanks.
Thanks for the questions. I'll take the open label study question first. As I mentioned, there were a high proportion of patients who rolled over into the open label study. That study is currently fully enrolled at 354 subjects, and that study is ongoing in terms of its design. The study was designed for subjects to receive up to 4 retreatments in the protocol, and this was designed to satisfy all of the FDA requirements, both in terms of the number of subjects treated across both ASPEN-1 and OLS, as well as the number of retreatments. All of the FDA requirements, as laid out and confirmed in the pre-phase 3 meeting, were carefully included in the protocol, and we will have met those at the conclusion of the study.
Thanks, Roman. This is Dustin. I'll handle the next questions around reimbursement. So as a current landscape perspective, the current payers do not allow retreatment of botulinum toxins as a category any sooner than 12 weeks. So that's why you're seeing those 4 times a year. And in some of the data that Roman presented, it talks about how patients have some of that wearing off at 8 to 10 weeks, but they're not allowed to get reimbursed or retreated until after week 12. From a daxibotulinum type A for injection perspective, while we haven't fully fleshed that out, we don't anticipate any restrictions as relates to only 2 times per year. So we'll take this data, we'll compile a very compelling health economic story to payers, and we'll come back to you after that. Thanks, Annabelle.
Okay.
Great, thank you. Our next question comes from Serge Belanger with Needham. Your line is open.
Hey, good morning, and congrats on positive phase 3 results. First question is another follow-up regarding the open label study. Can you just talk about how much dosing flexibility there is in the study, and whether you expect that duration will be extended with retreatment? And then the second question regarding dysphagia. Saw a significant difference between DAXI and the other neuromodulators. Can you talk about that difference and maybe the importance of reducing dysphagia in this patient population? Thanks.
Sure. So in terms of the open label study, the subjects are eligible for up to 4 treatments over a 52-week period, and clinicians are able to increase the dose across 4 different doses. We haven't disclosed the actual dose levels yet, but we'd wanted to give them the flexibility to increase the dose if they believe that the patient could benefit from a higher dose. These doses are known to the investigators, so in other words, if they start out at one of the middle doses and decide that either a higher or lower dose is more appropriate, they do have the flexibility to be able to implement that treatment decision. Could you repeat your question on dysphagia?
Yeah, can you maybe explain why DAXI leads to a significantly lower incidence of dysphagia, and how important is reducing the incidence of dysphagia in this patient population?
Sure. So in terms of dysphagia, it's one of the most feared complications of neurotoxin treatment in this condition, and it essentially is a marker of spread of the neurotoxin outside of the intended target muscles. one of the primary reasons for the low rate of dysphagia is the low rate of core neurotoxin that was present at the doses studied in the ASPEN study. So as I mentioned before, it ranged from 0.57 nanograms to approximately twice that. And in conjunction with the low amount of core neurotoxin and the stabilizing peptide, which allows for increased uptake at the intended site of action, which in this case are the cervical musculature, we were able to administer the product at the intended area with very little spread outside of this. Other complications of cervical dystonia that are of interest and also of concern include muscle weakness and difficulty breathing, which we saw very low rates of for both of these categories, just like dysphagia.
Great. Thanks, Serge.
Thank you. Our last question comes from Jacob Hughes with Wells Fargo. Your line is open.
Hey guys, congrats. Could you just, Mark, maybe you could just comment on any potential read-through that you see here to upper limb spasticity and the PF data, and do you think ULS is significantly powered given the pandemic? And then the other question I had was just on the treatment adverse events. There looks like there was one unrelated death. Maybe you could just comment briefly on that as well. Thanks.
Sure. So, first off on the read-through, and then I'll hand it over to Roman to hit some of the questions on the clinical trial side of it. But obviously, as I mentioned earlier, it increases our confidence now that we've seen consistent and compelling results across our 2 phase 3 programs that we've done. Certainly ULS, being a muscle movement disorder, we have, I think, higher hopes now for that phase 2 data based on this readout. Plantar fasciitis, it's hard to say. This is a sort of a new indication. It's a little more complex. We made some changes. So again, we remain cautiously optimistic, and obviously, addressing a pain component in the cervical dystonia data gives us, high hopes on the plantar fasciitis phase 2 trial. I think more than anything, it just continues to sort of validate the performance profile and the unique nature of it compared to all the other neuromodulators on the market. So again, we have increased conviction, and we look forward to kind of taking all this data and rolling it into sort of our study plans going forward. With that, maybe I'll turn it over to Roman to talk about, kind of the one death in the trial, and then your other question as well.
Sure. So I'll take the safety question first. There was one death that was observed in the study, was unrelated to treatment, as evaluated by the investigator. The cause of death was not disclosed to the investigator by the family for privacy reasons. In terms of the Juniper study, we did elect to close enrollment at a total of 84 patients, and with this sample size, we are confident that we will be able to evaluate the primary endpoint, that is the comparison of 3 doses of DAXI compared with placebo, with at least 80% power, and that's based upon the efficacy of other neurotoxins in the space that have been published. So the primary goal of that study is to provide guidance and information with regard to dose selection for the subsequent phase 3 study that we're eager to lock the database at the appropriate time for evaluation assessment and then guidance for future efforts in this indication.
Thanks, guys.
Great. Thanks so much.
Thank you. I'd now like to turn the call back over to Mark Foley for closing remarks.
Great. Thank you all for taking the time to participate in today's call. Please follow up with us if you have any additional questions, and hope everyone has a great day. Thank you.